Good evening, everyone. Thank you for being here this evening. I'm Pauline Matandan Garcia. I am the Director of Care Transition for Livingston Memorial VNA and Hospice. I will be moderating tonight's presentation. Our topic this evening is diabetes awareness and management. Before I introduce our speaker, I want to just go over a few housekeeping notes. So tonight's session will be recorded and will be posted on our website so anyone can access it post presentation. If you have any questions for the speaker during the presentation, please feel free to use the chat function in Zoom to submit your questions. We'll do our best to answer all the questions during the presentation, but we'll also post all the questions and answers on the website as part of the webinar. If you run into any technical difficulties, please feel free to use the chat function as well to send me a message directly so we can assist you. So tonight's speaker is our very own Linda Hampson. She is our nurse diabetes specialist, and she recently celebrated her 30th work anniversary with Livingston. Before joining Livingston, Linda was actually a professor at Ventura College, part of the ADN, as instructor for the ADN program. She also attended Columbia University, where she earned her bachelor's degree in nursing. And also she also earned her master's degree in nursing at Cal State Dominguez Hills. More importantly, that I want to highlight is she, before Livingston, she also served in the military as a Navy nurse during the Vietnam War. Linda is passionate about one-on-one diabetes interaction with her patients and educating the community on diabetes management. She's an avid traveler. She has visited more than 30 countries as part of her bucket list. And in her personal time, Linda enjoys yoga, walking, volunteering, and wine tasting. So without further ado, Linda Hampson.
Good evening, Pauline. Thank you for having me. This is an enormous subject, and we only have 45 minutes, so it's going to be something, an overview, and I want to know that I'm focusing primarily on type 2 diabetes and pre-diabetes. Because of the time limits, we're not going to be able to cover everything I'd like to talk about. But first and foremost, I will deal with some medications. I will not deal with insulin. And so if you're an insulin using diabetic, some of the things that I will say about meal planning may not be appropriate for you. Next slide. This is a busy slide and you don't have to read it all, but I'd like you to know that the information that we share with you about best practices for diabetes management, in my case, come from the American Diabetes Association, and they revise their standards of care, their recommendations every year. And the only reason I bothered to put this up here is not so that you read every single bit of it, but so that you know that diabetes is not just blood sugar management. You'll see that other things are addressed up there: sleep, hypertension, renal disease, lipid management, and all of those are important to an individual who has insulin resistance. And so next slide, please. As a matter of background, the fundamental physiology of type 2 diabetes is something called insulin resistance. And the markers for insulin resistance, how you might know you actually have this, first and foremost, family history is the first clue. But insulin resistant people have elevated blood sugar, they have elevated blood pressure, they have elevated LDL cholesterol, and you notice that there's an unhappy face there. How you remember good and bad cholesterol is L stands for lousy. That's the sticky stuff that you don't want to have. You have not enough HDLs, and you see the happy face there. They're the good guys. Those are the pipe cleaners. And classically in insulin resistance, you have too many pipe slimers and not enough pipe cleaners, which sets up an ominous situation in your vessels. The other hallmark of insulin resistance is central obesity. That means weight gain around the middle. That's the apple configuration. And as opposed to just a big bottom, the fact that you are genetically programmed to collect your weight abdominally also infiltrates all of your internal organs, and so it has medical significance. And those are the kind of markers that we look at for someone with insulin resistance. Next slide, please, James. So what causes insulin resistance? First and foremost, it's your genetics. No two people have exactly the same genetic breakdown that leads to elevated blood sugar, but genetics is the primary cause of insulin resistance. And the force that drives this genetic pool is age. So as you age, it gets worse and worse. Now, you can't do anything about your genetics or your age. And so let's deal with the things that you can do something about that may impact this fundamental insulin resistance. And if you look at that blue cell there, you see the key with the door. This is how I explain what insulin resistance means. It's a cell level problem. And if you can imagine, that cell is covered with doors. And insulin, which you're actually making lots of, are the keys that unlock the doors so that glucose can get from your bloodstream into the cell where it's used for energy. The problem is that you have rusty hinges on all those cell doors. The doors don't open wide. And what do we do to get those doors open? Well, next 2 points are weight control and movement. They're WD-40 for hinges, if you will, and that's why we can advocate so strongly for those 2 points when we're talking about the management of diabetes. If you can make your cells more sensitive to the insulin you're already making, you can rebalance your blood sugar. And it's a lot of work, but it's very achievable. Next slide, please. So if you're new to diabetes, you need to know what an A1C is. And our treatment goals for the management of diabetes basically are to keep you from getting complications. And I know you're all well aware of what the complications are. And what we know for a fact now that we did not know historically is that it's not the duration of the disease that leads to the diabetes complications, but rather it is damage done to blood vessels by chronic exposure to elevated blood sugar. And the A1C test, which is done every 3 to 6 months, is an overview of what your blood sugars have done 24 hours a day for 2 to 3 months. And so there's no fooling the A1C. It tells us how effectively we're achieving our goal, which is basically to protect your blood vessels. And so we deliver the A1C to you as a percentage, as you can see on the chart there. And there's a star at 7. When you read the literature about diabetes management, you will typically see, or at least according to the American Diabetes Association, a treat to target goal of an A1C of 7. And what the right column shows you is what that percentage translates into in terms of something that you can understand. These are the numbers that you get when you test your blood sugar. So you can see an A1C of 7 is an average blood sugar of about 130 to 200. And the good news about the treat to target goal, although that's not normal blood sugar, is it is the safe point for your blood sugar. Can you, next slide, please, James. Quickly, let's review the things you don't want to have happen to you: blindness, kidney failure, amputation, stroke, impotence. Heart attack is in red because heart attack is far and away the #1 cause of death in diabetes by about 4-fold. And these are the things that you want to avoid by controlling your A1C. Next slide, please. This is a busy slide, and the only place I really want you to look is at the number 7 across the bottom. And what you see is complications are on the vertical axis. The horizontal axis shows you as A1Cs go up, the eye problems, the kidney problems, the neural problems, the urine spilling problems, they increase dramatically as your blood sugar goes up. And so this is a risk graph. And the point of making an A1C of 7 our goal is that seems to be the point where blood vessel damage occurs. If we can keep your A1C under 7, then with a fairly high degree of confidence, you can expect to be able to avoid the complications that we all are so concerned about. Next slide, please. Can you reverse diabetes? Let's look at the numbers. On the left, at the center column where the numbers are fasting blood sugars, you'll see that normal fasting blood sugar is 70 to 100. We diagnose pre-diabetes when the fasting blood sugar is between 101 and 125. And you have diabetes when your fasting blood sugar is 126 or above. This is a number-driven disease, and so we have to have guidelines. And what we've done with the introduction of pre-diabetes about 10 years ago is, I call it a heads-up consultation. If you have those markers or some of those markers for insulin resistance that I referred to earlier, and you have a fasting blood sugar between 101 and 125, and how do they know this? It's about the fifth test down when you have a chemistry panel done on your annual physical. So your doctor will see that. And he may say something, or he may not say anything, depending on whether there are other markers to indicate that this very modest blood sugar elevation is significant in terms of progression to type 2 diabetes. The A1C on the right shows you that a normal A1C is 4 to 6%. The A1C that we have defined as prediabetes is 5.7 to 6.4, and you might scratch your head a little bit and say, how can I have prediabetes if it's 5.7 and 5.7 is normal? A1C is not a test that's done routinely. It's a test that is triggered by other numbers. So if you have a prediabetes fasting blood sugar of 101 to 125, they're very likely to order the A1C to find out if this is significant of our concern, which is it a marker for progression to type 2 diabetes, which we hope to be able to do something about. One of the ways I describe the situation in terms of our increasing numbers are our fasting numbers, 70 to 100. If you can imagine, that's the parking lot. And the pre-diabetes number is 101 to 125. You're standing on the beach. And once you arrive at a fasting blood sugar of 126, you're starting to wade in the water. And the higher your blood sugar goes, the further you're getting from the beach. And the reason I like to use this analogy, particularly for prediabetes, is I like to tell people if you can still see the beach, then there probably is a really good chance with some effort on your part that we can get you back into the parking lot that is normal blood sugars. And we may be able to do that without the use of medication. Now, you may have heard that some people with prediabetes are started on metformin, and the deciding factor about whether or not we treat prediabetes with a medication is how extensive your risk factors are, how likely this is to progress. Most of the time, we will deal with those things that I talked about earlier that were in your grasp, which is basically weight control and activity. And if we can utilize those things appropriately to make your cells more sensitive to insulin, the insulin you're making will, I like to call it rebalance. I think you read about it, is it possible to have remission? Whatever word you decide to use, you have to understand that we are not curing type 2 diabetes. If we make your numbers normal again, your genetics are the same and age is going to continue to happen. And the management of diabetes is a proactive process that you have to keep your nose to the grindstone for. But remember what your reward is. And early on in the disease, it's much, much easier for this reversal or rebalancing process to happen. If you've had diabetes for a long time, it's not very likely we're going to get you back to the parking lot. The longer you've had it, the more help you're going to need in terms of support to manage your disease. So next slide, please. Activity. Remember the two things we talked about, which were weight control and activity. And I no longer use the word exercise because it seems to suggest to people that you have to buy funny clothes and sweat and go to a gym. And the kind of activity that's necessary to impact insulin resistance is not of that intensity. The guidelines state that you need to increase your activity by 30 minutes a day, at least 5 days a week. And I would like you to take this seriously enough to believe that the activity is powerful as any medication we can give you. And you don't take medication 5 days a week. It's something that you do every day, and I would like you to incorporate at least some effort in that direction. The good news is you don't have to have 30 minutes of activity all at once. You can incorporate a cumulative activity in the course of the day and ideally reach 30 minutes more than you are doing now. Resistance exercise is also something that's been added in the last about 10 years. And resistance exercises are things like rubber bands or soup cans or things that make you work your muscles. And our objective is not to have you build muscle, but rather to make sure that you maintain the muscle that you have, because guess what? Muscles burn glucose. And the healthier your muscles are, the more effectively you will burn glucose, which certainly is a method for glucose control. So if you see the continuum on the bottom, it's an activity continuum I use. On the left side, you see sitting. And I've invented a word. I'm sure you'll not find it anywhere, and I call it unsitting. And it's the first step in being more active. We are an extraordinarily sedentary population. And what I like to show you is, although none of us are going to run marathons on the far right, it doesn't take a great deal of activity to impact favorably sensitizing these cells, making you less insulin resistant. That's not to say that if you are able to engage in activity longer or at higher levels, as that star moves to the right, you certainly will reap cardiovascular benefits that are not happening at a much lesser level of activity. And calorie burning is something that is very effective with more intense activity. So know that if you can do more than that star, great. But if you can't, know that that star is a place where you can successfully address your level of insulin resistance. So if my support staff pays attention here, at 7 o'clock, I'm going to ask you all to stand up and walk in place for 2 minutes while I continue to talk, because the latest American Diabetes Association guidelines, standards of care for activity, have determined that a person with insulin resistance, you all, should never sit for longer than 30 minutes at a time without interrupting that period of time. And at 7 o'clock, if we all remember, when I tell you to stand up, you're going to see that 30 minutes goes by rather quickly. And I would like you to think about times when you routinely sit in the morning, having your coffee with the newspaper, in front of the computer all day long, at night, watching television, reading books. We have many, many, many activities that are very, very sedentary. And the latest research is showing us that our sedentary behavior is as much of a contributor to insulin resistance as obesity is. Everyone is aware of that component, but activity has sort of been the stepchild. And it turns out that it is not a stepchild. It is equally important, and it is something that everybody can engage in. Even if you are limited in your ability to move, even if you use a walker, it's not so much how far or how fast you go, it's a matter that you are moving and you are not sitting. So remember my unsit word, if that's really a thing. And let's move on to the next slide. Okay, it's important to understand how a pancreas works, because everything we do in diabetes management is to make diabetic blood behave as much like non-diabetic blood as we possibly can. And so a healthy pancreas does two things. It produces basal insulin, or background insulin, which means it trickles out at a constant low level over 24 hours, just a small amount of insulin, whose purpose is basically to control your fasting blood sugar. And fasting blood sugars are the most challenging thing to control because they are the most physiologic. They are least related to your behavior. The other thing that a healthy pancreas does is produce what's called bolus or on-demand insulin. And this is an enormous problem in people with type 2 diabetes because a healthy pancreas is chock-a-block full of stored insulin. And if a person without diabetes sits down and eats a whole box of See's chocolate, their body has the tools to defend against that behavior, and their blood sugar stays normal. If you look on the right side of that graph where you see 70 to 180, that's your body's warm fuzzy zone. That's where it likes to be. And when all the tools it has are working properly, you can defend against any behavior and maintain your blood sugars. So what you see is a graph there, and basically that's your glucose tolerance test, but it shows you that the blood sugar rises very quickly when we give you syrup to 180, down to 140 at 2 hours, down to 120 at 3 hours, and back to recovery time in about 4 hours. And that's about how a glucose tolerance test normally looks. If you have diabetes, it's not going to look like that. Also understand with elevated blood sugar, the higher your blood sugar is, the less well your beta cells, the insulin producing parts of your pancreas, work. And so one of the things that happens with extraordinary high blood sugars when we're using all kinds of medications and being very, very, very strict with your diet is that we can get your blood sugar back down. Your beta cells will work better. They will make more insulin than they do in the face of what we call glucose toxicity when your blood sugars are very high. So we really want to change those circumstances as quickly as we can. Everything about diabetes, when you attend a seminar like this, is an overwhelming amount of information. You think my head is going to blow up. How can I do all these things? And I absolutely don't want you to think that way, because diabetes management is a change in direction. It's steps in a better direction than where you are. It's clearly not an all or nothing proposition. So if today you hear even one thing that you haven't considered in terms of your diabetes management that appeals to you, that you think, gosh, I hadn't thought about that, I might be able to do that. That's the most important takeaway message today. You're not striving for perfection, you're striving to avoid the deterioration of this disease. Next slide, please. I'm going to talk about medications now at first, not because medications are the most important. What you have to know is medications are a crutch. They are something the medical community puts in place once your best self-management efforts are not achieving the goal that will protect you from complications, or if you have complications, from your complications getting worse. So I talked about the tools in your toolbox and the different mechanisms that diabetes uses to control your blood sugar. So on the lower right where it says pancreas, the older drugs, glipizide, glyburide, and glimepiride, which were the original diabetes drugs, are all pancreatic stimulators. They work by trying to nudge more insulin out of your pancreas. And they are all capable of producing low blood sugar reactions, hypoglycemia. If you go up to the top where it says liver and metformin, metformin works through your liver. Metformin is our primary monotherapy drug. If you are started on a medication, the first medication you will be started on is metformin, unless your kidney function doesn't support the use of that drug. Metformin's primary job in life is to correct fasting blood sugars, which are the hardest thing for you to address with lifestyle only. Metformin suppresses the inappropriate release of glucose from your liver during the night. And if you are testing your blood sugar, the reason you're testing in the morning is to see if your metformin dose is doing what we want it to do, which is basically reset your baseline, your fasting blood sugars. Lower left where it says cell, the next group of medications that we developed were addressing the fact that insulin resistance is the primary physiology of type 2 diabetes and Actos and Avandia are the two drugs that were designed to specifically address insulin resistance. Both of them turn out to have quite a bit of baggage and are not used initially. They have some contraindications with heart patients, work real well on some people, not well on others, but they're not a primary drug. Now, if we move over to the mid-right where it says GLP-1, this was our next batch of drugs that addressed yet another mechanism that we use, that your body uses to control blood sugar. And these drugs also, it's glucagon-like protein 1 inhibitor, and they all work through your digestive system, your GI tract. The ones on the bottom, the Januvia, Glyza, Tradjenta, and Nacina, are oral agents. They're pills. I call them sleeper drugs because when you take it, it does nothing until you put food in your stomach. Food is the trigger for these drugs to go to work, which is basically to stimulate your pancreas to make extra insulin available while your blood sugar is rising. Above the GI tract are all the magic new drugs. Those are all Ozempic, everybody knows Ozempic because it's on television. And I think Kim Kardashian took it. And those are all injectable drugs. Those are the weekly guys. Ozempic, Trulicity are weekly. Victoza is the other primary one. That's a daily drug. And these drugs are like the Januvia, Glyza, Tradjenta drugs, only really revved up. They do the things that the oral agents do, but in addition, they do something called slowing gastric emptying. And gastric emptying is the peristalsis that moves food from your stomach through your digestive system. The food you eat isn't actually absorbed into your bloodstream until it leaves your tummy. And if we slow the rate that food leaves your tummy, then it gets into your system slower. And if it gets into your system slower, you have less of a blood sugar rise. And that's a good thing. But the collateral benefit of these injectable drugs is that the slowed gastric emptying is a big inhibitor on how fast or how much you can eat, because you can only put so much into a tummy that's not exiting at the rate that you're used to. And the most common side effect of these drugs is nausea and bloating and tummy kind of upset, which we very carefully can address by learning to eat slower. And interestingly, when you learn to eat slower to avoid the stress, your satiety center in your brain, which takes about 20 minutes to kick in, and most of us eat in faster than 20 minutes, so we don't have time for all of that, will kick in and tell you that, golly, I think I'm full. I don't have to finish everything on my plate. And we're programmed to clean our plates, so there's a lot of supertentorial business going on here, but do know that these drugs, these injectable drugs, are very, very successful with weight loss, and we are having the best luck we've had in many, many years helping people lose weight with these drugs. Ozempic has about a 20% weight loss in 6 months success rate in many, if not, but certainly not all people. So they are a consideration. When you hear something that sounds too good to be true, know that these drugs are very expensive and sometimes difficult to get. Slide over to the kidney on the left. And our newest, and they're not new, family of drugs that utilize yet another part of our system, our toolbox to help control blood sugars, work through your kidneys. They're called SGLT2, sodium glucose-like transporter 2 inhibitors. And what they basically do is your kidney is a filtration organ. It filters every drop of blood in your body, and it gets rid of, in the form of urine, the waste, and puts back in the good stuff that you're supposed to keep. And lo and behold, if we can rev up the mechanism that causes your body to spill more glucose, it has a dramatically good effect on your blood sugar. And it affects both the fasting and the prandial, food-driven side, as do the GLP-1s. So it's kind of a dual purpose drug. The underneath kidney, it says Brenzavvy, that was just released about a month ago. So we have a large collection of SGLT2s now, and they are interesting group of medications because they are the only ones at this point that have the FDA, the Drug Administration approval, because of special studies that were conducted, to be prescribed for people that do not have diabetes because of their cardioprotective properties. They are being prescribed for heart failure patients now in non-diabetics. I could zip over to the Ozempic side and tell you that Wegovy is a form of Ozempic in a much larger dose that can be prescribed to non-diabetics for the purposes of weight loss. So these newer drugs are having expanding implications. The kidney drugs are also being looked at now as having some potential renal protective property. And of course, kidneys are an end organ of concern for people with diabetes. So this is just to show you the 5 mechanisms by which we use the medications. Okay, 30 minutes. It's 30 minutes are up. I just want you to stand up while we are talking, and then we'll move on to the next slide, which is food. This is a nutrition label, and there are 2 big red arrows there. Serving size and total carbohydrate. That's what you look at. Do not look at sugar. Sugar is just one type of carbohydrate. And when we are going to carbohydrate count from a label, you need to know how many carbs it has and how much of this product your manufacturer is talking about. There are salads at Trader Joe's that say serve 2. So you need to be very aware if you're going to be a carb counter. Next slide, please. Okay, what you're looking at here is the magic red line. It worked very hard to get that on there for me. The blue line is a normal blood sugar curve. The red line is what happens when an individual without diabetes eats. And what you see is about 2 hours out, food peaks or drives blood sugar as high as it's going to go in a non-diabetic person. So it's all driven by carbohydrate, and your identification of carbohydrate is extraordinarily important, because if you eat more carbohydrates than your pancreas can make insulin for, you're going to get the blue line instead of the red line, and then your A1C is going to go up. So there are a couple of things, and this is really important. 1, 2, 3 down in the on the right side. There are 3 things you can do, non-drug based, that can mediate the red line, make it even better than it is there. You can take a walk after a meal, and what I highly recommend is a 10-minute walk, 5 minutes out, 5 minutes back. You can increase the fiber content of your meal. We typically, because we eat so much processed food, don't consume an adequate amount of fiber. Fiber is a buffer, and it slows carbohydrate absorption. And in certain meals, if you can manage it, if you eat the carbohydrate portion last, then the food that precedes it is a buffer. So those are little tricks that you might take away that help mediate blood sugar rises. Now, on the top right, you see 30 to 45 grams of carbohydrate in capital letters per meal. People are always wanting to know, how much carbohydrate can I eat? Well, it's different for different people. It depends what medications you're taking. It depends whether you have a high A1C and you're trying to correct it, whether you're trying to maintain. But generally, 30 to 45 grams of carbohydrate per meal, not per day, is a reasonable range. And if you snack, and I'm not a big encourager of snacks, if we're causing you to have low blood sugar, we should change your medications. But 0, that's wonderful things like veggies and nuts, to 15 grams of carbohydrate for an optional snack, if that's something that you have comfort level with. Next slide, please. Okay, so where are the carbs? Starches, breads, cereals, and grains, starchy vegetables, and I want to tell you the primary starchy vegetables are peas and corn. You expect to know about potatoes and hard shell squash, yams and sweet potatoes. Those are starchy vegetables. Just about every other vegetable in the world is what I call a free vegetable. You don't have to count it in your carbohydrate content. Crackers and snacks, beans, lentils, peas. Fruits, all dairy, and all sweets and desserts are primary sources of carbohydrate. And if you are carbohydrate counting, these are the things you need to pay attention to. And I'll give you an example. The beauty of carbohydrate counting is that you get to choose which carbohydrates you want to put on your plate within the framework of your carbohydrate guideline. Sit down if you're still standing. Give you an example. If you go to Wood Ranch, if you're there for the rolls, you get 2 rolls, and there's your 30 grams of carbohydrate. Now, your meat, fish, chicken, eggs, cheese, nuts, none of that is carbohydrate. So you can have your tri-tip and you can have some veggies, but you've just used your carbohydrates up on the rolls. If you can't eat tri-tip without beans and corn, there's your 30 grams of carbohydrate. Now you don't get any rolls. But the choice is yours, and the beauty of carbohydrate counting is you can prioritize things for your tummy and your tastes. So next slide, please. Very quickly, because we're running out of time, sources of fiber. These are foods that are high in fiber, and fiber is a buffer. They are all healthy, and they all help to mediate blood sugar rises. So I'll leave that there for a second longer for you to peruse. I don't think there's anything up there that's a big surprise, but because we eat so much processed food, you'll see that's more what you might consider to be natural food, which is higher in fiber. You'll also notice that everything up there is plant-based. Next slide, please. So types of meal planning, there's no diet word there. Carbohydrate is the most effective means for lowering an A1C. If your blood sugar is high, carbohydrate counting is going to be most beneficial. If you're a pre-diabetic and your A1C is not elevated, calorie counting is going to be your primary goal. You are going to work primarily on losing weight as a pre-diabetic because carbs are not an issue for you yet. The circle on the right is basically the plate method. And you'll notice that that's a 9-inch plate, which means it's a luncheon size plate, not a dinner size plate. And it's half vegetables, half your carbohydrate, and half what your protein is. And basically, that's only a 15-gram carbohydrate. So you could have a piece of fruit, you could have a glass of milk. But the 9-inch plate is the key here because your brain is a whole lot happier looking at a small plate that's full than a large plate that you put small portions on. You've heard of the Mediterranean diet, and basically it's a healthy eating plan. There are not that many Mediterranean countries that are still following the Mediterranean diet, but basically it's a simple, healthy food diet that includes whole foods, no processed foods. It's light on red meat, it's heavy on fish. It's a very, very reasonable diet. It's very healthy, it's very heart healthy. The DASH diet, if you've heard about that, is basically a low sodium diet or a low sodium version of the Mediterranean diet because you don't get to eat all the olives and good things. Flexitarian is not quite a vegetarian diet because it includes some meat. Keto is very popular now. For those of you who are older, keto is the same as the old Atkins diet. It is a carb-starving diet. It is effective for weight loss. It's not a sustainable diet. It's not something that you can stay on for a long period of time. I typically, in most of my patients, don't object to briefly doing some keto to get some weight loss starting. Not going to work for your insulin people, and so you need to talk to your physician if you're using insulin, or if you're using SGLT2 inhibitors, the kidney drugs, where hydration is so important. So if you're undertaking any of the more extreme diets, you should do it through consultation with your physician. And there's one more diet I didn't put up there, but is pretty popular now, and I'm going to call it the intermittent fasting diet. And I'm not going to say a lot about it because there are 3 or 4 different ways to achieve this thing we call intermittent fasting. It also is a weight loss diet. The most common and easiest one is a time-restricted diet where you only eat within between 8 and 12 hours a day. Once again, it is for the purposes of weight loss, and it's a matter of what you can be comfortable with. Next slide. We're going to go through this really fast because we're running out of time. Simple swaps to help you with lower blood sugar. We're talking about substituting cauliflower for rice. We're talking about using Greek yogurt instead of regular yogurt because it's higher in protein, it's lower in carbohydrate. Next. Plain oats instead of instant oats. Nuts. Nuts are your friend. Nuts are monounsaturated fats, so they are heart healthy. They don't have any carbohydrate in them, or at least in their natural state. If you're talking about peanut butter, you can look at the label and see anywhere between 2 tablespoons of peanut butter may have anywhere from 3 to 13 grams of carbohydrate, but that's because of sugar added by the manufacturer. So nuts are a great healthy snack. They have lots of protein. They're good for satiety. Sugary drinks, well, enough said about that, I think you know. I put an unhappy face here by pasta sauce because if you look at the labels on most of the pasta sauce, it's got an extraordinary amount of added sugar. It's very high in carbohydrate. And so this is a suggestion about how you can make some simpler versions of tomato sauce that are heart healthy and much, much lower in carbohydrate. Next slide. Have you got a zoodler? Zoodler is a tool that turns your zucchini into spaghetti. Or you can use several other squashes, but what we're doing is substituting pasta, a vegetable noodle for pasta. And you'd be surprised, it's remarkably good. You can actually buy it in the grocery store if you don't have a zoodler. Mash a banana. If you freeze it, it's not quite ice cream, but I'll tell you, it surprises you a little bit. You can spread it on toast. Banana turns out to be a fairly decent substitute. Next slide. Make your own dressing. You know, I don't have a huge issue with salad dressing in moderation. I don't typically count salad dressing in your carb count. If you're going to drink a whole bottle of salad dressing, I think I would address this differently. But I want you to concentrate on where your primary carbohydrates are and juggle those. Now, cottage cheese is a poor stepchild, and cottage cheese turns out to be a marvelous filler food. You can do things like put sugar-free Jell-O powder into cottage cheese and stir it up, and it's not quite ice cream, but it's pretty tasty. You can do things like put Splenda or Truvia and cinnamon into cottage cheese and make a dessert-like thing. You can use it as a salad with things like pico de gallo. Although cottage cheese started out as a dairy, most of the lactose, the milk sugar, is removed in the processing. So you can count your cottage cheese as a freebie unless you're buying cottage cheese and pineapple, in which place you can read the label. Next slide, we're gonna make it. Blood sugar monitoring. Basically, we have blood glucose monitors by finger stick, which are on the left, and there are a multitude of different tools out there, and the one you have is probably the one that your insurance company is willing to pay for. They are all FDA approved, and there are all kinds of different ways to use the monitor. Don't be buying these yourself. If you get a prescription from your doctor, your insurance company will pay for a monitor and strips. If you're on Medicare, they may limit it to based on the kinds of medications that you're taking, but everybody has access to a monitor and strips through their insurance company with a prescription for their doctor. If we weren't out of time, I'd go back to that other graph and show you the different ways that you can use the tool, but basically the reason you test fasting blood sugars in the morning is to make sure your metformin dose is doing what it does. If your fasting blood sugar is 100 and you eat and your blood sugar goes up to 140, that's wonderful. If you are 200 when you start to eat and you eat perfectly, your blood sugar is going to go to 240. That's not so wonderful. It's not a function of what you ate. It's a function of your blood sugar being out of range when you get out of bed. So monitoring can be very useful in the course of the day to measure the effect of food. You can use the monitor to measure the effect of exercise. It's a wonderful, wonderful tool. On your right, you see the continuous glucose monitor. And sadly, it's not sad, but in my opinion, this is the greatest invention since sliced bread. The sad part of a continuous glucose monitor, which is that patch you wear on your arm, which is actually a sensor that you need only to hold your smartphone over with the app applied, and it gives you a continuous readout of what your blood sugars are doing without any kind of invasive procedure. So you have constant feedback about everything you can do with the continuous glucose monitor. Sadly, it's not readily accessible. The insurance companies are very, very judicious about who they will pay for monitors for and whether or not you're using the right drugs. So I don't want to spend too much time on it because it may not be accessible to you, but know that it exists and is an extraordinary tool and a motivated person to know exactly what's happening all the time from their best efforts. And they have just released in the last 3 or 4 months something called an Eversense 3, and it is an implantable chip. It's good for 6 months. It's an office procedure that's a poke and a stick, and you have your sensor in place for 6 months. So that's the latest evolution in the world of continuous glucose monitors, which on your screen, as you can see where the 141 shows you, graphs your blood sugar. It will alarm you for highs. It will alarm you for lows. It's an extraordinary tool, and I hope against hope that the insurance companies will become much more relaxed about making them available to more and more people because it's a great tool. There's our class schedule. I do classes in Camarillo, Simi Valley, and Thousand Oaks. So there's also a class in Leisure Village, but that's not accessible to anybody except residents of Leisure Village. And they're monthly. And if you're interested, I hope to see you there. And that's about it for today.
I have a couple of questions that came up.
Sure.
The first one is there a best fruit for people with diabetes?
Yes. And that fruit would be the one you like. There's nothing that a diabetic can never eat. Carbohydrate counting allows you a great deal of juggling. And the meal plan for diabetes should be a meal plan that you'd like. And we can manipulate and adjust and substitute almost anything to make a meal plan that satisfies you. So when somebody asks me about the best fruit, it's going to be the fruit that you like. It's like somebody asking what the best medication for diabetes is, and I hate to tell you what the answer to that is. It's the one that actually gets taken. And you have to take your medications for them to work, and there are unfortunately a lot of barriers to medication use and medication acquisition. But the best fruit for you is the fruit that you like in the context of what the rest of the meal is. Got anything else?
Last question that I have is metformin. I've heard metformin is bad for kidneys.
Yeah. Metformin is our primary drug, the first drug that we will start you on. And remember, it fixes fasting blood sugars, which are the hardest thing to fix. But metformin is a very interesting drug. It's been around since the early 80s in Europe, since the early 90s in the United States. And it's a drug that we have an extraordinarily huge database of information on. And what we found from our big database on metformin is that metformin has all kinds of collateral, non-diabetic, beneficial properties. Long-term metformin users, for example, have women who have lower incidences of breast cancer, to the point that they're actually doing research with metformin for its cancer properties to see if that's it's a fact as it seems to be. And as we look back through this database, we're finding that metformin users have lower levels of intestinal cancer. They have lower levels of lung cancer. There are chemotherapeutic benefits to the use of this drug. And as we dig through the database, we're finding all kinds of things. Everything from glaucoma to dementia appears to be lesser in long-term metformin users. And so anytime you hear something that sounds too good to be true, you should say, okay, where's the other shoe? And the other shoe with metformin is that it may deplete your vitamin B12 levels. And if that's the case, and we are looking for it, we'll give you a sublingual vitamin B12, and you'll go right on taking our metformin. Metformin does not hurt your kidneys. Metformin is cleared through your kidneys. And if you are on metformin and we stop the metformin, it's because your kidney function is not adequate to support the clearance of the drug. The drug did not hurt your kidney. Metformin is a very safe drug.
If there are any other questions, please feel free to send them via the chat, or you can also unmute and ask the question directly to Linda. All right. If there are no other question, I want to thank everyone for attending our webinar. Like I mentioned, we also added on the chat box the full recording of the presentation as well as the slides that we used today will be available on our website within the next couple of days. If you have any questions after the presentation, please feel free to reach out to Linda Frank. She will direct the question to Linda Hampson. Yeah, thank you so much and have a good evening. Bye-bye.
Thanks for joining us.